Good afternoon, everyone, and welcome. Thank you for joining us today. Today we are on to our next webinar in the INNEG series, and we are looking at neuropsychological evidence, particularly focusing paediatric brain injury. And we're delighted to be delivering this session in collaboration with Parklane, Plowden Chambers. So I'm very pleased to introduce our speakers today, and before I pass you over to them, first of all, we have Dr. Nigel Colbert. He is a consultant clinical paediatric neuropsychologist with over 10 years medico-legal experience. He undertakes all reports on all areas of medico-legal input on both clinical negligence and personal injury matters, and acts both on behalf of claimants and defendants. He holds the British Psychological Society qualification in neuropsychology and appears on the Specialist Register of Neuropsychologists, and I think he'll touch upon that a little later on. We are also joined by Hylton Armstrong of Parklane Plowden, who is a specialist barrister in PI and clinical negligence matters. He acts also for claimants and defendants in a range of serious and high-value injuries and has extensive experience in these areas. So today's presentation will be slightly different from a normal in that it will take the form of a structured discussion between Hylton and Nigel. And I'd just like to remind the audience that, first of all, the recordings will be available afterwards on our website and will be emailed. The details will be emailed to you following the event. But also at the top, you'll see the Q&A function. And that's quite important, particularly for this session, because as we go through the discussion, Hylton will be keeping an eye on the Q&A. And if there's anything which is applicable throughout the discussion, he may bring those in to the session and the discussion with himself and Nigel, albeit at the end, there will be a bit more of a formal Q&A, which we will try, time depending, to get through a few of the issues discussed and broken and mentioned. So without further ado, welcome, Nigel. Welcome, Hylton, and I will pass it over to you. Thank you very much.
Thank you.
Thank you, Leo. So, paediatric brain injury claims are sometimes approached through an adult lens. Things like a seemingly early recovery, reassuring imaging, and acceptable school reports can give the impression that all is well. Yet for many children, the most serious consequences of a brain injury are not immediate or obvious. Instead, they can emerge later, when the child is expected to start to manage complexity, independence, and risk. As Leo said, I'm a barrister with some experience of acting in cases involving children with neuropsychological injuries, and Nigel is a consultant clinical neuropsychologist with extensive experience of treating and reporting on cases involving children with brain injuries. Together, we're going to have hopefully an informal conversation about those subtle symptoms and hidden problems and their long-term outcomes, and discuss how we can best use neuropsychological evidence within the medico-legal process to help us identify evidence and present a good or bad case. The conversation you're about to hear might be quite fluid, but the aim is to start with some of the basic concepts, then introduce the concept of causation, before finishing with some general chat about tricky issues, hints, tips, and pitfalls. Nigel, I thought we'd start the first section of our conversation by talking about neuropsychology as a discipline and neuropsychologists as experts within that discipline. In terms of neuropsychology as a subject, we've talked about this a little bit between ourselves, but do you regard it as a pure science, a bit more of an art form, or a bit of both?
It's a good place to start, because I think, as with all clinical, applied clinical sciences, It's both. It's a technical discipline with the necessity of having access to a range of neuropsychological tests and instruments, and also having the background knowledge of childhood development. But then it's relational as well. One of the key things that differentiates pediatric neuropsychology from adult neuropsychology is the relationship can be key in terms of getting the young person, the child, to do their best on the tests, which are often quite onerous. They can be uncomfortable, and there's less of an emphasis on, in the pediatric world, on effort testing, which is, those of you who also work in the adult world, you'll know that effort testing is a feature of that work. We often have to balance being objective and measured and doing a standardized assessment, but at the same time encouraging the young person, the child, to do their best. So from that point of view, it's an art and a science. And the hardest assessments I have to make are desktop assessments. When I haven't seen the child, I haven't sat with the child or the parents or the carers, because there's a lot of information that we gain from being with the child, the young person, and their carers. That qualitative information that informs the quantitative results that we get. So from that perspective, we're often combining the quantitative information, and that's the technical side of it, and there's a lot of work goes into that, and we can talk about validity and reliability of test measures and instruments, but also that qualitative information, the answering the so what question for this child or young person. Because as you said, Hylton, in your really informative introduction, even the language we use of rehabilitation is not really applicable to some of the children we work with, because we're not rehabilitating them to any position, because there was not an a priori position before the event. We are working in a habilitation way, and often the questions about how far they can go, questions that typically come up about employability, social skills, educational prospects, are very much informed by what we know, but we don't have a baseline measure to go with.
Yeah. Okay, so Nigel, you talked about this concept of balance as a subject between the technical and the relational, the quantitative and the qualitative, and the difference between adult and pediatric cases. As far as the practitioners within the field of neuropsychology go, what do you think makes a good, balanced clinician?
We can address that from the for barristers, solicitors, rehabilitation agencies, is what makes a good, or makes a neuropsychologist even in the UK, is, and I'd be curious to know from the participants how many people are familiar with the specialist register of clinical neuropsychologists. So to be a neuropsychologist in the UK, very much like in the US, now requires one to do further postdoctoral training in neuropsychology. And the postdoctoral training in neuropsychology is a D-level qualification, and it's managed by the British Psychological Society. And it's not a trivial thing. It requires further training, what they call a knowledge base. It also requires 3 years of supervised clinical practice, as well as a knowledge of research in the area. And to be on the specialist register was always designed to be the gold standard. So someone who achieves the specialist register, gets on the specialist register for clinical neuropsychologist, who's got the qualification in clinical neuropsychology, and they're not necessarily the same thing, has developed over time that knowledge and experience. So
Nigel, that's a really good start for everybody watching and listening to think about when they're trying to find the right expert in their case. Beyond being on that specialist register, what else do you think lawyers should be looking for when selecting an expert?
For me, often the questions that are being asked are about the young person's praxis, their ability to function in the world, be that home or school. So a neuropsychologist who's got experience of community rehabilitation can inform the report through that lens. So I've worked in community-based rehabilitation, not hospital-based, but community-based rehabilitation for 2 decades. And that informs the report, that informs that so what question. It also gives you the insight. So my, full confession here, my supervisor when I did the qualification training was an educational psychologist. I work in an organization called Clinical and Education and Neuropsychology. So I'm a clinical psychologist by background. My wife is an educational psychologist. So I have a lot of insight and understanding of what goes on in the education system. And so in the pediatric world, it's probably worth pointing out that there's 2 flavors of pediatric neuropsychologists. Those who previously trained as clinical psychologists and those who previously trained as educational psychologists. And it may be, depending on the focus for your neuropsychology report or the questions you're asking, you may want to differentially choose between the 2, or choose somebody who has, I wouldn't say a foot in both camps. That would be misrepresentation. My sort of skills. I am a clinical neuropsychologist, but that makes a good neuropsychologist, I think.
Okay,
someone
so
who
we've
can
got
form the relationship.
We've got their kind of route to practice, be that educational or clinical. We've got them being on the register, and then we've got that underlying community experience. You've mentioned a couple of times already, Nigel, this what you call the so what question. Just for the uninitiated and to make it clear, do you mind just briefly explaining what it is you're talking about?
So often in our instructions, sometimes we get quite detailed instructions and they're very helpful to us, asking questions about educational prospects, employer expectations, social community activities, whether a young person can be expected to have normal family relationships, raise a family, etc. And sometimes we're asked to comment on consider the child from a neuropsychological point of view. And certainly when we've had a conversation about this before, it's even talk about what neuropsychology is and what the scope of our work is. And it covers 2 interesting areas. One is intelligence, which is controversial. And I think the other one is consciousness, which is also controversial. Consciousness is, well, just recently, I think at Christoph Koch and David Chalmers. David Chalmers was gifted famously a crate of nice Madeira wine because we have still not cracked the code, the neural correlates of consciousness. So that kind of goes into the personhood of the individual. What is it like to be that individual? What is their sense of self, their sense of agency in the world, and how can we support that? And that's reflected in, I think sometimes the goals for the child have to be ecological to that child and that family. Because as a parent, I think most people would agree that our goals for our children are for them to be healthy, happy, and to have friends. Having 9 GCSEs at grade C and above may be a target and a goal for the education system, but it's a rare goal for any of the children that we work with.
Yeah. So we may, Nigel, not crack the code of consciousness in our conversation today, but what we are going to talk about is some of the basic concepts around symptoms. This conversation is all about hidden symptoms. So we've talked about neuropsychology as a subject, we've talked about neuropsychologists as experts. Let's talk about what neuropsychological symptoms are. And do you mind briefly explaining how you think they can be different when it comes to adults and children?
As a pediatric neuropsychologist, you have to put everything within the perspective of a child's normal developmental cycle. And the things that we're interested in, and I think the things that the cases are interested in, is the child's social development, the emotional development, behavioral aspects, and intelligence. And I touched briefly on intelligence before, but intelligence testing is about getting a measure of the young person's capability for being adaptable, flexible, coping with the world. And we can talk about different sorts of intelligence and how we measure that. But we're also very interested in social development. So there's often an overlap in syndromes between children with an acquired brain injury and children who might be considered to be on the autistic spectrum. Behaviorally, there's often features of attention deficit hyperactivity disorder in the children who we work with. And NHS services and to some extent educational services are siloed, and they will consider children in each of those different diagnostic boxes. With an acquired brain injury, you have a brain that's suffering from a dysmaturation. So an interesting analogy that's been made from a child perspective by Nicole Rust, who's a neuroscientist, is in neuropsychology, it's a complex dynamical system of brain maturation. And what we're doing is more like weather forecasting than doing discrete causal chains, that if this has happened, then, you know, we can expect this to work out. Early changes in disruption of neural development can have large consequences over time. And the analogy I often use is those of us who've had children and the growth charts that the midwife and the health visitor plots our child's head circumference, and you know, they're all very narrow at the bottom and very close together, but through time they differentiate. And that's what we often see, and you referred to it earlier, Hylton, is these delayed deficits and difficulties and differences when children get to different stages of their school career.
Yeah, so you're describing a complex picture with social and emotional and behavioral and intelligence type issues floating around, and different clinicians and departments being in their silos. Is it possible to generalize a bit and talk about when and how these early subtle problems do tend to emerge?
Very often what we find in primary schools is the difficulties are I think there was one neurologist in a report recently I read, and he had used a lovely phrase, which is primary school reports are often upbeating. They're often very positively framed. Skills are developing and they're emerging. And children in primary schools have very few demands in terms of executive function skills that we'll go on and talk about. So a good example of a hidden difficulty in a primary school with a young man who I still work with now was I was told he had no difficulties in primary school and he was understanding the lessons, the instructions, and was quite capable. So I went to watch him and observe him, and that's often a very useful thing that sadly since COVID, we're less able to do. And I watched him in a PE lesson. And what this young lad did was he was always 30 seconds behind his peer group. So the instruction would be given, run across the hall, touch your toes, run back again. And what I noticed was he wasn't understanding the instruction. He was copying off everybody else. So we're often the Cassandra who goes into the primary school and says, well, actually, that small delay in reading, that small delay in writing, that small delay in understanding instructions is going to get quite manifest unless we do something about it now. And typically teachers will say things like, well, they're not the worst in the group. They'll catch up. And we have to be quite, I think, consistent to get those early interventions in place so those children get the environmental changes and adaptations they need so they can close that maturational gap.
So, Nigel, I'm not sure my parents would agree that my school reports were always upbeating. But on a more serious note, you've explained how, with everyone's best intentions, real problems can get missed through the lens of school and school reports. Is it possible to sort of say what difficulties are most likely to be dismissed by teachers or other people coming into contact with children? And related to that, what therefore are the red flags that we as lawyers should be looking for in a child client's history?
For me, I often suggest that no firm understanding is possible until the young person has transitioned to high school. If they're in a mainstream school environment or even a resourced provision environment, then the transition to high school is often where we see these difficulties emerge, because what's masked in junior school is what we call adaptability skills. Thinking now about the human brain is it's a prediction machine. It's constantly trying to predict what's going to happen next. And if I know what's going to happen next, there's no surprises, everything's fine, we're okay. But if a surprise occurs, an unexpected change in routine, the fire alarm goes off, then the children we work with can go into a hyperarousal mode. And that's where we often get a lot of the behavior disturbances, the behavioral outbursts. The child is in a class with all their peer group and they tend to move en masse. They don't have to plan, they don't have to organize, and they don't have to inhibit their emotional responses. But when they get to high school, the whole situation changes. They often have to suddenly step up a gear in terms of planning, understanding a complex timetable, navigating around a geographically much bigger area. And that's often when we get behavioral disturbance.
Yeah. And my understanding, Nigel, from cases is that connected to this is that there's a difference in approach between primary school and secondary school teachers, and secondary school teachers are not generally perhaps quite as upbeating as you say. Is that correct?
I have to be careful here. Both my daughters are teachers, and my wife's an educational psychologist, as I said before. My eldest daughter is a primary school teacher and a Senko. My middle daughter is a high school teacher. And they would say that the curriculum, well, the middle daughter is a science teacher, would say, high schools are very much focused upon delivering a curriculum in the time that's available. And the 9 GCSEs, they are a different beast to that kind of nurturing, caring, supportive environment to get in primary school. And so the children that I work with often fall through the cracks in that system. It's a bit like the old Pink Floyd, another brick in the wall. It's an industrial scale approach. And our children need a more nurturing, supportive, facilitative approach.
Okay, well, we've talked a bit about subjects, experts, symptoms, how they manifest, and how and when to potentially spot them. Should we move on to think of things through the medical legal lens, and in particular talk about sort of medical legal diagnosis and causation, and maybe start with a couple of straightforward questions about the types of evidence that we see. I think it might help if we box off what you think is the realistic role of conventional imaging when it comes to these subtle paediatric cases.
Without stepping on, obviously, an imaging expert, neuroradiology and neurology is often the imaging that we get is, if it's done in sort of an emergency situation, it's a CT scan. CT scans are very good for determining, blood. We get MRI scans, which are structural scans. But what they don't pick up is functional abilities. They're often, and again, I defer to other experts in this, is we don't have many imaging techniques that are available to us routinely that show how the brain works in the real world, if you will. There are techniques available using quantitative EEG and evoked potential ERP work, such as Yuri Kropotov uses, where you can test psychometrically a child, a young person, or an adult, and actually get metrics of brain function or dysfunction. Because the literature now supports the view that it's not particularly about focused brain lesions or damage. It's the structural integrity, the networks within the brain that are often the most informative in terms of what difficulties that child or young person is going to have. And to get an insight to those network functioning, you need to get real time, if you like, working data on how the brain is communicating and working.
Okay, so if there is a limit to conventional static imaging, the next sort of layer of assessment that might jump out to people listening is psychometric testing. There's obviously differences between adult and pediatric testing. My understanding is that certainly in the adult world, it's corroborative, but not necessarily determinative. How do you think psychometric testing can be used and relied upon in the absence of conventional imaging demonstrating an identifiable injury?
Psychometric testing, I think, is fundamental to what we do as neuropsychologists, and how we go about using those instruments is one of the marks of what I would consider to be a good neuropsychologist. And I would say that first things to consider are what instruments and tests are you going to use? What we sometimes find is that there's one test for children and young people, the Wechsler scales, which are ubiquitous and are quite widely used. And that can bring its own problems because of children being tested by multiple experts at short intervals. And so there's a learning phenomena. So a good neuropsychologist has a range of different tools that are validated. So I use the Woodcock-Johnson test, the Wechsler tests. If a child is of low ability or non-verbal or doesn't have English as a first language, we also need to have access to a range of non-verbal tests as well, such as the LITER. And even then, we may have to rely on something like the cognitive abilities profile, which is an interview-based format. So we can get a real-world idea of how the child is able to perform. So one of the things that I would say is I don't get assistant psychologists to do any testing. I always do the testing. And that may add to the overall cost, but qualitatively, if I'm examining a young person, how they approach the testing can be as informative as what the actual scores are that they achieve on the test. And specific examples of that can be things like a child who approaches a maze task and they have to, like a puzzle we used to get in puzzle books, you have to navigate to the end of the test. And I've worked with children who just shoot straight off and get stuck. And we know that the latency typically is about 1 second. A neurotypical person would look at it for a second and then begin. So I know that they've got an impulse problem. If they're doing a digit span test and they're talking to themselves, I can often see the lips moving. If they're visualizing it, you get a different response. Or even if they use the opportunity to write things down in a mathematical reasoning test, which they're offered. Some children just don't do that. They try and do it all in the head, or they use their fingers. So qualitatively, I'm getting to see how that child approaches what can be quite a difficult task, what encouragement they need. Do they need to go and self-regulate between the sub-tests, or jump up and down on their trampoline or what have you? So that gives me a really good insight as to how they're able to work and what and the scores will give me a good metric for how they're going to achieve educationally.
And if you do that whole range of testing in the right way, it sounds like it can be very informative. What else would you put on the list of things you need to plug in to your assessment of a patient to conduct an effective assessment and reach a well-rounded opinion about the diagnosis?
Thorough history taking, conversation with the parents, a chat to the parents about their experience of being a parent, the parents' own educational background and employment history. We know that, and this is controversial, that IQ is heritable. So given what we were saying about habilitation and rehabilitation, we have to try and determine what that child's educational capacity would have been but for the index event, the negligence. So looking at the parents is giving us a good idea of where they're going to come out. And also going into school, speaking to school as a minimum, and finding out how they perform at school, both academically and socially. Are they isolated in the playground? Do they have a good peer group? Are they a confident learner? And then we can supplement that qualitative information with behavioural measures, different questionnaires that can be sent to home and school, and then we can triangulate the two.
Yeah.
Do they do better in one environment than the other?
We talked earlier about how some subtle problems can be concealed in a primary school setting, for example, and then become apparent in a secondary school setting. In terms of a medico-legal assessment, is there a, generally speaking, ideal time to do or to not do the kind of assessment that you've described?
I always like to see how they get on at high school. So for me, it can be very useful to have done an assessment when they're at primary school, and then we assess them at about the time they transition to high school, certainly in terms of their executive function skills. And we have some observational schedules and some questionnaires about their ability to control their emotions, but also to plan and organize their schoolwork and so on. So the transition to high school and see how they get on at high school, I think is, for me, is a really important factor.
So let's say you get the assessment right, with all the right testing, or all the right other factors, you've timed it right, and you can get a reliable diagnosis. On the causation issue, how do you, as a neuropsychologist, demonstrate that those problems, or that problem, was caused by a specific incident?
The first port of call is the literature. The literature in the paediatric population is less dense than the adult population, because in children's work, and this is one of the challenges we face, every child, every young person escapes every diagnosis. They're all a very heterogeneous group, different circumstances, different injuries, different family. So they're all quite different. But we can, first of all, go to the literature and use that as a baseline, that we do know that certain networks, certain like the frontal lobes, and we often talk about the frontal lobe syndrome in our reports, can be associated with these delayed difficulties. And I think we often, colleagues and I, we refer to the sleeper effect. The child does okay at primary school, then we get these problems I've spoken about at high school. And that can be because these frontal lobes don't come online at the appropriate developmental stage.
So you can use the literature and you can say, well, certain problems are more likely to be connected to certain events. What if we plug in somebody who has a pre-existing neuropsychological type disorder? How much more difficult does that make it? And is there a difference between people with very severe pre-existing problems or much less severe, possibly not very clear, pre-existing histories?
In terms of causation, that's, and I know that that's one of the questions we often get asked in conference, is we know that there are lots of overlaps between these different syndromes, as I've mentioned before, that dysmaturation can manifest in terms of communication difficulties, social difficulties, emotional behavioral regulation difficulties, or specific learning difficulties. If the level of injury is quite profound and the young person has a learning disability as opposed to a difficulty, then that can have an overarching impact on their functional skills in everyday life. We know that children, for example, with a cerebral palsy have high rates of autistic spectrum condition difficulties and also ADHD difficulties. So disentangling these things is often that art form, if you like. It's that qualitative, trying to make sense of the narrative that the child may have had what I refer to as a reduced reserve capacity to cope with the injury, if it's a road traffic accident, if they had a pre-existing diagnosis of ADHD, for example, and then they have a road traffic accident, their capacity of their brain to remodulate, to cope with, to adapt to may be reduced because of the pre-existing difficulties. So we're now talking about different modifying variables and the resilience of the brain to reorganize itself and make different network connections.
So this is where the art form comes in, trying to link one thing with the other and distinguishing between something else. When you see other experts try to do this, either when you're perhaps with the claimant, you see in defendants' reports or vice versa, what are the mistakes that you see other experts making when trying to bridge the gap, for want of a better phrase?
I think we sometimes fall into the trap of we're almost becoming neurophilosophers at this point, because in terms of a reductionistic approach to neuropsychology, that if we identify a specific brain area, it will lead to a clear causal chain to this outcome, is not possible because of those complex multi-dynamic networks that we've spoken about before. Sometimes I see experts overreaching in terms of the evidence that's available. So they may record significant differences in performance on different metrics, but what they're not reporting is the baseline is, well, actually, that's a quite common difference because there's obviously natural, quite a wide range of variation in the population. And so sometimes trying to fit the data to a narrative can be a difficulty. Sometimes using a metric that's not, the floor level is too high for the young person that you're assessing. So they've used a metric that goes down to, say, age 7, and this is an 8-year-old, but maybe you should be using a measure that starts off much younger than that and goes higher, because they've got to get some traction when they're doing the assessment so they can move forward and give you. So sometimes you'll get the child scored, baseline, this level, 0. And that's not a good reflection of how that child would be able to do, I think, on a different test on a different day.
Well, listen, Nigel, I'm conscious of the time. So what we're going to do is just move to sort of the last bit of what we're going to talk about, which has a bit of kind of trivia type feel to it for you, I'm afraid. We're going to ask you some questions about medical legal reports and experts. So for you, in a few words, what makes for a good report?
I think what I try and do, and those of you who've seen my reports or may say otherwise, is I have, looking at data analysis as a discipline, is it starts off with, and you mentioned earlier, Hylton, about blocks. We have Lego blocks scattered randomly, and the first job that we have to do is sort those different, interview, psychometric tests, and we need to sort those into order. And that's the first level of sorting out our Lego blocks into size, color, what have you. But then what you want in a good report is that needs to be constructed into some sort of model of that child in their environment so it makes sense. And that's the making sense part that the experience of a neuropsychologist with our core professional training and then the additional training, it's making sense of the data so it captures that child, makes human sense of that child in their environment, and projects as best we're capable of their developmental trajectory of where they're most probably going to be able to get to in terms of employment and social life.
When you're writing a good report, Nigel, is there any part of it, or is there ever a time when you particularly feel sort of most vulnerable to criticism? And I'm asking that so that we as lawyers, when we read reports, can perhaps get behind the eyes and into the mind of experts.
The getting behind the eyes is a really good insight. When I'm doing a psychometric test on a young person, I'm putting myself in their shoes. If they have a short-term working memory that's 2 or 3 items, what would the world seem like to me if, you know, the world was a buzzing, blooming confusion and I can't remember anything? So that insight, having sat with the child and seen how they react, for me is incredibly helpful. Where I feel vulnerable in a report is if I've not seen the child or if there's a gap in the data. So I've not been able to interview the school, or I've been asked to rely on another expert's quantitative measures for whatever reason, the child's not available for testing or so on. That makes me feel vulnerable. And sometimes I think we just have to be honest and say, we need more time. You know, we need to wait. So that watchful waiting that we spoke about before, you're asking for a decision now, and I'm kind of saying I'd rather wait till they got to high school.
In terms of other things that you'd rather then, Nigel, another question I had for you was about what you would change, if anything, about the way we as lawyers try to run these cases.
I have 2 hats. I often think I work as a rehabilitationist and I do reports for the court. There's not a lot of conversation between the two. And I think it would sometimes be really helpful for the children, the young people, their families and their schools, if there was more dialogue between the expert and the rehabilitation psychologist or the MDT as a whole. And I've had this where I'm the rehabilitationist, the expert is referred to in hushed tones, and I'm sitting there thinking, well, I don't think their reports captures the whole child. So I'd like to see cases where truly the child and the young person was at the heart of the process. I understand the reasons for jointly instructing case managers, but I think a case manager at best is a really good advocate for the child and young person. So I'm more comfortable with you know, single instructions. And as I say, that my expertise doing the Part 35 report could filter down and help inform now the child's education and their rehabilitation, rather than being kept in a separate vault, if you will.
Okay, well, just to maybe bring our conversation to a bit of a close, Nigel, I suppose as we probably knew but have definitely heard, that the absence of early deficit does not equate to a good outcome in the long run, and apparently reassuring evidence, perhaps at primary school, can mask difficulties that only emerge as developmental demands, as you've described, increase. I suppose for lawyers, the challenge is not simply understanding some of the basic neuropsychological concepts, but recognizing when the evidence is strong or not, because perhaps it's premature, incomplete, vulnerable to criticism in relation to the expert, testing, or some of the legal issues around causation. Sounds like the way to do that, part of the way to do that, is to spot things as the child matures and transitions, evidence it properly and creatively, involving a dialogue between clinicians and the medico-legal team, and then present it as coherently a narrative as possible that includes all the relevant information and evidence. So Nigel, thank you very much for sharing your insights so helpfully and candidly. I hope the discussion for everybody has helped them develop a clearer framework for identifying risk, asking the right questions, putting, as Nigel said, the child at the heart of the process, and approaching these cases with the degree of caution that they require. So, Leo, perhaps if I hand back to you. I've been keeping an eye on the Q&A, but will confess I haven't seen any questions pop up.
Well,
I don't know if there are any in the background.
First of all, thank you very much, both Hylton and Nigel, for that very insightful session. I personally really enjoyed that, and I'm sure I speak on behalf of everyone here watching that was really very insightful. So thank you very much, both. Before we just jump to the Q&As, and there are a couple, I want to mention and flag our next webinar on Wednesday, the 4th of March. And as we're talking about paediatric injury, Dr. Ujwal Karahalu, consultant neonatologist, will be joining us in a couple of weeks. So look out for those details, and we look forward to that next session. There are two questions here, and again, let me know if there's enough time to answer them fully. The first one is from Alison Johnson, who wanted to ask Dr. Colbert, from what age generally can a child with brain injury be assessed to provide a neuropsychological prognosis? And I appreciate you've probably touched upon that, but maybe if you can just clarify, is there a specific age, or is it that sort of range across the time frame?
That's a good question. So in terms of the psychometric measures that I have available to me, the Woodcock-Johnson test of cognitive abilities starts at the age of 2. So we can get scores on the doors, if you will, from as early as that. Whether that's truly meaningful or necessary is another question. Probably by asking the teachers how they're doing and asking the parents how they're doing and comparing it to normal, like the PIP developmental charts in terms of the motor skills, the cognitive skills, looking at their communication skills in terms of communication, reciprocal turn taking. We can do all those assessments at a very early age. And that might then indicate, certainly early on, that this is a child who is going to need speech and language therapy very early. So the sooner you get the speech and language therapy in, the better. Similarly with occupational therapy, because those are the foundational skills that a child needs. Because one of the things that maybe I didn't stress enough is we know that the internal working model that the child develops is very much influenced by their ability to be an agent in the world. So I can communicate and get feedback. I can operate on the world and get feedback. And that structures the cognitive development. So it's imperative that we identify those needs very early on and the appropriate members of the MDT get involved. So
Thank you.
We can be doing that very early on.
So from 2, but if not 2, from very shortly afterwards. So thank you for that. And one more question currently here from Rebecca Peary. Why are children with CP more likely to also have a diagnosis of autism or ADHD?
Well, if I could answer that question, yeah, I'd probably get a professorship somewhere. It's because of the way the brain works. As I said, it's a massively interconnected neural network. So we know that, for example, one of the things that we often do, and forgive us when we do a neuropsychology report, is we distort things, we delete things, and we generalize things. And it's almost a metaphor that we talk about, is we talk about frontal lobe syndrome. And that's almost a shorthand, because we know that, in fact, here we go, this is my the myth of executive function in the frontal lobes is there are massive interconnections between subcortical structures and executive function for motivation, impulse control, motor control, and so on. And in children with cerebral palsy, where those structures are also impaired, that then has a knock-on effect in terms of their attention, their focus, their concentration. And we also know then that some of the difficulties in children with autistic spectrum condition may be about impairment of visualization skills, which are associated with kind of social turn taking, linguistic skills in terms of understanding the spoken language. And then also, as I was saying before in my earlier talk about that predictive processing model that the brain is involved in, if we've lost some of that capacity and then things surprise us more often, then we're less flexible, we become more rigid, we want to stay in our lane, we don't cope well with novelty, and those will then manifest and be labelled as ASC, ADHD, etc. So it's because of the massively interconnected nature of the brain.
Thank you. And a late question has just popped in, and maybe I can ask if you can answer this with one word, yes or no, because I appreciate it sounds like it will be one which will develop into a long conversation, and perhaps we can follow up with the two solicitors directly. Kay Barnes and Emma Hudson have asked the same question, whether you have, Nigel, experience of DTI images and TBS studies and relying on fractional anisotropy to evidence compromise, if I pronounce that correctly.
So I'm aware of them from the literature, the diffuse sensor imaging, again, looking at it's referring to these networks that I was speaking about. So it's talking about the communication superhighways within the brain. So I'm aware of it from the literature. I have yet to work on a case where that evidence has been presented.
Thank you very much. And with that, everybody, thank you very much for your time this afternoon. Thank you again to both our presenters, Hylton and Nigel. And I wish everyone a good evening and look forward to seeing you again very soon at the next INNEG webinar. This webinar was in conjunction with Parklane Plowden, and we're delighted to have both of you presenting today. Thank you and have a good evening all.
Thank you.